Good afternoon. I'm Nirja Shah with the Illinois Chapter, American Academy of Pediatrics. Thank you for joining us for today's webinar on Influenza 2015-2016 updates. This webinar is sponsored by the Illinois and Chicago Department of Public Health. Today, we are joined by LJ Tan of the Immunization Action Coalition for the first half of the webinar and Shelley Ann Allen from Families Fighting Flu for the second half of the webinar. In accordance with the requirements of the FDA, the audience is advised that information presented in this continuing medical education activity may contain references to unlabeled or unapproved uses of drugs or devices. Please refer to the FDA approved package insert for each drug and device for full prescribing and utilization information. The course director, planners, faculty, and reviewers of this activity have no relevant financial relationships to disclose. Evaluations will be sent post-webinar by Rush University with a link to the survey to be completed. Once the survey is complete, you will receive your certificate via email from Rush within a few weeks of completion. If you're going to watch the webinar in a group, instead of your own individual link or computer, we will need the group's information after the webinar by this Wednesday, the 9th at 4 p.m. in order to be added to the registration list we send to Rush University, and you will need to complete the evaluation post-webinar. Please send an email if you haven't already to nshah@illinoisaap.com with names, credentials, and a valid email if you are not logging into the webinar from your own personal link or computer. Otherwise, CME/CNE credits will not be awarded. Participant phone lines are muted. This webinar is being recorded. If you have any questions for our speaker during the presentation, please enter them into the question box on your control panel on the right side of the screen, and Dr. Tan will answer them at the end of his presentation. After this webinar, you will receive an email with a link to the recording of today's webinar as well as a PDF of the PowerPoint slides. Now, I would like to introduce Dr. LJ Tan. LJ Tan is a Chief Strategy Officer for the Immunization Action Coalition. Prior to that, LJ was the Director of Medicine and Public Health at the American Medical Association for 15 years. Dr. Tan also serves as co-chair of the National Adult and Influenza Immunization Summit, together with the CDC and the NVPO. Dr. Tan recently served on the National Quality Forum's Adult Immunizations Expert Committee. He currently serves on the Pharmacy Quality Alliance's Adult Immunization Working Group, the European Society of Clinical Microbiology and Infectious Diseases Vaccine Study Group, and is an editor for the Journal for Disaster Medicine and Public Health Preparedness, BMC Infectious Diseases, and Medscape Infectious Diseases. He just completed his term as an elected member of the Federal National Vaccine Advisory Committee. He still serves on their HPV and Vaccine Confidence Working Groups. Previously, LJ chaired the Immunization Infrastructure Work Group and also served on the Vaccine Safety Work Group. Dr. Tan also served as a liaison member of the Federal Advisory Committee for Immunization Practices, ACIP, for 12 years and still serves on their Adult Immunization Working Group. Please join me in welcoming Dr. LJ Tan.
Oh, there we go. Can you hear me now? Hello?
Yes, we can.
Oh, wonderful. I'm sorry. I couldn't hear. I just heard silence and I didn't get any response back. So I apologize for that. Wonderful. Thank you. All right, this is great. So let me go ahead and share my screen, which I've already done. Start my slideshow. Can you all see my slides now, Nurja?
Yes.
Okay. Fantastic. Thank you. All right. Well, thanks so much for this opportunity to talk to all of you regarding influenza. And because Shelley's following up after me, I'm going to try to run through this fairly quickly because I think a lot of this is going to sound familiar since we're already kind of into the influenza season. I think she has a compelling story to tell, and I think hearing that story is probably almost as important, if not more important, than hearing a lot of statistics and data on influenza. So a couple of quick disclosures. I'm not going to spend too much time just going through this. Just to let folks know that I do serve as scientific consultant for multiple commercial entities as an expert scientific advisor. But the honoraria is not kept by me. It's donated to the Immunization Action Coalition. A disclaimer also is that any opinions that I may express in this presentation are solely that of mine, my opinions, and they do not necessarily represent official positions of the Immunization Action Coalition or of that National Adult and Influenza Immunization Summit that I spoke of, that was introduced earlier by Nurja. And the reason for that is it's important since I do co-chair that with CDC and with the National Vaccine Program Office. It would be unfortunate if anything I said got misinterpreted as being the position of the CDC or VHHS. So that would get me, of course, in a lot of trouble. So again, this disclaimer is pretty important for me. A quick outline of what we're going to do in about 30 minutes or maybe a little less. Review the season that just passed and talk about coverage rates and talk about, obviously, vaccine effectiveness that we saw last year. We're going to then describe some of the flu recommendations as well as vaccines available for this upcoming season. And to say upcoming is actually right because flu is not really, has not really started in the U.S. yet. In fact, only Puerto Rico and Guam are reporting widespread activity, and only 4 states have local activity. So there's still plenty of time to get folks vaccinated. And then I'm going to spend a few minutes just to detail some of the communication strategies for the upcoming season, and spend a little time also talking about communicating vaccine effectiveness, simply because obviously, as many of you know, last season we did have that challenge with the mismatched vaccine strain. So quickly, just a summary of the 2014-2015 flu season. This is a typical graph that you see out of FluView, and I recommend folks, if you've never seen FluView Interactive, this is a wonderful program that CDC's developed, where you can go in and essentially kind of really mine the data for flu. And if you're a flu geek like myself, this is like one of the most fascinating things you can do is mine that data. But I use this graph really to show you a couple of things. If you look on the horizontal axis, that's the week of the season, obviously starting in week 40 through to obviously week 39. So it's a year of the flu season. And on the vertical axis, the y-axis, you see the percent of visits for ILI, where ILI stands for influenza-like illness. This is one of the many ways we measure actually progress as well as severity of a flu season. And I put this up there kind of just to indicate to all of you, and hopefully you can see my mouse here, indicate to all of you that if you look at the red triangle, which is the 2014-2015 season, is that we actually did have a pretty severe season last year. It was on the same severity as the 2012-2013 season. And like the 2012-2013 season, this season actually started about 4 weeks earlier than the typical average start time for a flu season, which happens around January and February, right around where my mouse is right now. And so this is just to kind of highlight this, that the flu season started about 4 weeks earlier last year, and it was about the same severity as the season in 2012-2013 as well, the blue line. The next graph is basically to focus in on pediatric influenza deaths, and I tend to vary this depending on the audience. And since this is the Academy of Pediatrics, I think it's important to kind of point out that if you take a look at this, we had a pretty bad season in 2012-2013. Last year, as you know, was the season that was dominated by H1N1, and then the season last year was obviously the mismatched year. We had about 147 pediatric deaths, and I highlight here that of the 123 kids that we had vaccination status known, 14 were not able to be vaccinated, 15 were fully vaccinated, but of that, the rest of that, the 94 that were left, were not vaccinated. They were unvaccinated. So we had a lot of unvaccinated kids among the 147 that passed from influenza the previous season. So that's something to kind of keep in mind. This next graph actually takes that pediatric data and actually brings it down just a little bit further. And I use this to actually highlight a couple of things. You know, we always focus in on children below the age of 5 years as being especially vulnerable to influenza. I used just to kind of show that, you know, that's not always the case. And in the previous season, as you can see, 57% of the children that passed from influenza last season were actually older than 5 years of age. You know, they were actually between 5 and 17 years of age. So I think, you know, this goes to highlight the necessity, again, of vaccinating all kids up to the age of 18. And in fact, as you all, many of you know, the ACIP recommendation is 6 months and older, everyone should receive a flu vaccine. So this is just to kind of highlight that point. Hospitalization rates in the previous flu season were actually pretty high. In fact, it was, if you take a look at the number here, you can see that this is, again, what it shows you is rates according to week, and on the vertical axis, it shows you the rates of hospitalization for every 100,000 of our population. And you can see our previous season, we were at about 65.5%, which is a remarkably high hospitalization rates for the season. And if we look at pediatrics, which is what we have here, I want to highlight that even with kids, and you look at the 4-year-olds and then 5 to 17-year-olds, if you look at the 0 to 4-year-old group, it was the second highest we had, and it was obviously second to that 2012-2013 season. So that's a pretty high hospitalization rate of about 57.4 per 100,000. And again, if you look at 5 to 17, while the hospitalization rates obviously aren't as high, they're still pretty severe this past season. They, in fact, for this age group, they were higher than what we saw in the 2012-2013 season. And it stood at about 16.6 per 100,000 population. So this is again just to bring out that while hospitalization rates were high, hospitalization rates in the children were even higher the previous season. So again, preventing hospitalizations is something that we know the flu vaccine does, and this is something that we want to try to focus in as well in terms of the when looking at vaccine effectiveness. I put this up here just to kind of basically show you the strains of influenza that were circulating in the season last year. And again, the yellow season is basically a type A strain of influenza that was not subtyped. But I want to draw your attention to the absolute lack of this color, which is the orange. This is the 2009 H1N1, and recall the season before this season. So this would be obviously the season of 2013 to 2014, that was dominated by the 2009 H1N1 strain. And this time around, it's actually dominated by an H3 strain, and there's absolutely no 2009 H1N1 in the previous season. And what I also would like to point out is that you can also see that there is that peak of the B season that we typically see that happens sometime in the second and third week of the year. And we see that as well in February and late March, the peak of B as well. So just to kind of summarize in words some of the data we had with regards to H3N2 last year, because many of you are aware, we did have that antigenic drift. And what antigenic drift essentially means with influenza is that the strain essentially drifted from the time that we made the call for producing a vaccine to actually what was circulating in this actual flu season. And the strain did drift away. And in fact, it was a pretty significant drift this past season. As it stands, about 18.6% of the characterized H3N2 viruses actually matched what was in the vaccine. The other 81.4% were actually drifted, so that they were not actually matching what was in the vaccine. The majority of this drifted strain, however, is now antigenically similar to the Switzerland strain, which is actually in our current upcoming flu vaccine. The one that's out there right now is actually now covers this drifted strain. So that's a good thing. Then if you take a look at, again, there was no H1N1, as I mentioned earlier. And again, 72% of the B strains that were circulating near the end of the season were of Yamagata lineage, which matched the trivalent and the quadrivalent vaccine. So in this year, almost 3/4 of the B strains were in both the trivalent and the quadrivalent vaccines. For those of you who will recall, the quadrivalent vaccines contains two different B strains to try to obviously capture the whole 100% of that spectrum. But the good news is that the previous season, almost 3/4 of the B strains that circulated were in both trivalent and the quadrivalent vaccines. And there was also a pretty good match in the vaccines for the vaccine strains to what was circulating as well. So in terms of B, I think that was good news all around in terms of that. So a quick summary of the activity that happened in the previous season. flu season began about 4 weeks earlier than usual. That's what we kind of talked about earlier, and disease was considered to be moderately severe. As I showed you, the peak of the disease activity was late December, early January, and as I said earlier, the H3N2 strains tended to predominate. There was absolutely almost no 2009 H1N1 strain at all. And again, we had that late season increase of influenza B activity with a peak in February and March. And again, we obviously had a season that was dominated by a drifted H3N2 strain, where I said almost 82% of the strains did drift. And then, of course, this also tended to dominate the media coverage of influenza last year as well. One of the things that I didn't show you is that, in the hospitalization rates, we had a dramatic impact on those over 65. They were the most adversely affected. The pediatric population was then second. And again, as I pointed that out, the hospitalization rate for children 0 to 4 years of age was 57 for every 100,000 population, which is pretty significant as well. Just a couple of points about vaccine coverage. This is to point out that this is so I'm shifting gears now. I'm moving from disease to now actually talking about how well we vaccinated our population. And I just want to point out that we covered about 59.3% of those of children between the ages of 6 months and 17 years of age. This is actually remarkable, and this is kudos to all you great providers out there who have done so well vaccinating our children. And I know this year has been a little more challenging because of some of the delays in shipments of the pediatric doses of vaccines. But again, this is a testimony to how well you all are doing. And of course, we continue to see improvements. 59.3 is an improvement from a 58.9% at the same time point from last year. And this is to be compared to about 43.6% of adults 18 years of age and older. So even the adults continue to improve. We're over a point higher than what it was last year. And so I think we're seeing a nice traction in terms of the social norm to vaccinate our children and to vaccinate ourselves as adults against influenza. So I think this is something that we're beginning to see some traction. Just to mention for all of you, in the adult world, there are a couple of concerns. One of the things we're concerned about is that even though the impact of disease on those over 65 years of age is pretty dramatic, we're kind of stagnant. We've not been doing very well vaccinating them. In fact, only 66.7% of those over 65 years of age was vaccinated. And this is actually very flat. And in fact, if you think about what we were vaccinating 65 and older in about 10 years ago, we were at about 72%. So we're actually not doing well with the 65 and older population. And the other adult population we're having challenges with, and again, use your bully pulpit. When you see your parents and you see their grandparents, I think this is an opportunity to highlight that not only do we want to vaccinate the kids to protect them, we want to vaccinate the adults to prevent transmission, but we also want to vaccinate them because they do have negative impact as well. And again, those adults with chronic medical conditions between 18 and 64 years of age, only 47.6% of those adults were vaccinated. And these are folks that have really high risk of complications should they get influenza, and so really should be vaccinated. So again, just a call out to use your bully pulpit to get people vaccinated. A quick discussion about vaccine effectiveness. And the reason I bring this up is just to highlight the fact that we did have that drifted strain last year, so the match was not at all good. And when you couple the fact that the match was not at all good with the fact that it was an H3 dominated season, in other words, we saw no H1 whatsoever, these adjusted vaccine effectiveness rates are not surprising. So if you look at all patients over 64 years of age, the adjusted vaccine effectiveness for last season was about 24%. And you can see that the best effectiveness, there was good effectiveness in those over 65, but following that you can see some really nice effectiveness in the pediatric population. But let's break that up a little bit, and you can kind of see where the effectiveness really was. It was in the B strain because we had a good match. If you take a look at the adjusted vaccine effectiveness for the H3N2 strain, you can see immediately the impact of the drift. That number drops to 13%. Again, the kids were a little bit better protected than, let's say, the healthy adults where we got no vaccine effectiveness whatsoever. And this is not surprising, again, because we had a season where it was dominated by H3N2. There was no H1, and the H3N2 that circulated was 82% drifted. So this is not surprising. We had a rough year with regards to the vaccine match, but I point out again that even then, we did see some benefits of vaccination, some effectiveness. So something to keep in mind as we start talking about vaccine effectiveness for flu vaccine. I put this up there because this was the subject of discussion with the ACIP this past year, and it actually led to a change in the recommendation that I will highlight in a few minutes. And the question obviously is, does the live attenuated influenza vaccine, or LAIV, offer better protection than the injected influenza vaccine, or IIV, against the drifted H3N2 strains? And this was a very good year to test that because of the fact that we had obviously that incredible drift in H3N2. And I will point out some of the previous studies that led to a preferential recommendation based on the fact that LAIV was potentially more efficacious against drifted strains. Obviously, we had the Belshi study from 2007, which you see here in the lower red box. And if you take a look at that, you can see that that's where it showed more effectiveness against drifted H3N2 strains. But as that was done, I also want to point out that there were two other studies that was done just before the Belshi study that showed that there was really no difference, if you take a look at these error bars, these are huge, between LAIV and TIV. And so there was already some uncertainty about this. And then when we took a look at the effectiveness estimates based on the previous season where we had almost complete mismatch, it is very clear that the adjusted vaccine effectiveness with huge standard errors, standard deviations here, standard errors and confidence intervals will obviously show that the LAIV is no more effective than TIV or the inactivated influenza vaccine IIV in terms of effectiveness against a drifted strain. And it was this data that led the ACIP to actually remove the preferential recommendation for LAIV for this upcoming flu season. So just something to kind of keep in mind as we go forward. Just with regards to vaccine effectiveness study, just to remind people that there are limitations to some of these studies. Obviously, there's a precision difficulty, as you saw from those confidence intervals being extremely wide. And when you don't have good vaccine effectiveness on the ground, you tend to need really large sample sizes. And obviously, our sample sizes, while large, were not large enough, hence the huge limited precision of these estimates. Again, these are all preliminary. There's a lot more data that needs to be gathered. And CDC are actually planning additional analysis to look at the effects of prior vaccination on vaccine effectiveness. And again, this is an observational study design, so there's obviously the opportunity for confounding as well. So just something to keep in mind. So summary of the vaccine effectiveness discussion that I've just given you. Again, the predominance of an antigenically drifted A strain, which you kind of know. The majority of the H3N2 positive cases were drifted viruses. We did see some protection against some of the H3N2 viruses, as you saw in the data I just showed you, and we did see good protection against influenza B, although the level of circulation of blue B was near the end of the season, and not as obviously as high as that of the H3N2 drifted strain. Again, there was no evidence of better protection for live attenuated versus inactivated vaccines among children against those drifted H3N2 strains. I put this up there because I think it's interesting. It's one of several studies that have come up showing the impact of influenza vaccination on preventing hospitalizations, not necessarily disease, but preventing hospitalizations. And I think what's interesting here is that it shows that sometimes maybe we need to look at vaccine effectiveness on the ground more than just in more ways than just incidence of disease, but looking at the impact of the vaccination on other outcomes such as hospitalization rates. This was a study that was just published in JAMA this year by Grijalva and his colleagues, and they looked at data from about 2,800 patients aged 6 months of age and older from the so-called EPIC study, which is the etiology of pneumonia in the community study. And what they essentially looked at is that they looked at patients, again, this is kind of a case negative type study design, which is really, really good. They looked at patients that were hospitalized with community-acquired pneumonia. Then they looked at, of those patients who were hospitalized with community-acquired pneumonia, which of these were influenza pneumonia, and then who had been vaccinated or not vaccinated. So again, a case negative design. And if you look at influenza vaccination, it was about 56.7% effective at preventing hospitalization due to influenza pneumonia in patients with community-acquired pneumonia. So very effective in preventing hospitalizations as a result of influenza. This is the actual data, table from the actual data, and I highlight the pediatric data. And I think it's important to note that if you look at the 6 months through 4 years of age group, the vaccine is actually remarkably effective at preventing hospitalization as a result of influenza pneumonia. So something to kind of keep in mind as we think about vaccinating our kids. It's not just about keeping them from getting flu, but it's also keeping those who get flu from being really dramatically impacted by with hospitalization. So something to kind of keep in mind as well. And in fact, this is how CDC is beginning to look at this. This is a graphic that came out of CDC, and basically it takes a look at vaccine effectiveness in terms of the negative outcomes that are prevented because of vaccination. And so they took a look at the last 2013 through 2014, and they said, this is what we did because of flu vaccination, because of the vaccination rates we were at. And remember, I showed you some national data. This was probably about 43% total of the population. About maybe 55% of pediatrics were vaccinated during that season. The estimated number of illnesses prevented, about 7.2 million. Medical visits prevented, 3.1 million. And again, that hospitalization point, 90,000 hospitalizations prevented. So I think one of the ways we're starting to talk about vaccine effectiveness for flu is not just in terms of preventing disease, but also preventing severe disease and bad outcomes as a result of that. So something to kind of keep in mind as we go forward. And this graphic, as you can see, is available on the CDC website. So I'm going to spend a final time for the final few minutes just going through some of the vaccines out there, and then also reminding folks about the ACIP recommendations that have been issued with regards to flu. So the 2015-2016 flu vaccine strains have indeed been changed, obviously because of the drift, and we have new seasonal influenza vaccine formulations, and of course they contain that A Switzerland H3N2-like virus, which is obviously that drifted strain. So our vaccine this year is likely, almost certainly, going to be a good match for what is circulating. And in fact, the initial surveillance data would suggest that there is a nice match for the vaccine. So just to kind of run through some of the vaccines that are out there, just to remind folks that we do have a quadrivalent vaccine, which contains 2 influenza A, so the H1N1 plus the H3N2, and then 2 of the flu B strains. So this, again, is this idea that, because the B strains can drift between one type versus another type, the Massachusetts versus the Yamagata, for example, what we're trying to do is, with the quadrivalent, we're going to have both of them in there. Therefore, we cover the possibility of a mismatch of the B strain each season. There is a price premium for the quadrivalent vaccines, but our biggest challenge right now is that while we have multiple manufacturers providing vaccines, quadrivalent vaccines, there is no clarity on how many total doses of quadrivalent vaccines are actually available this upcoming season. And in particular, I want to point out Sanofi continues to have both the trivalent and the quadrivalent formulations on the market simultaneously. And just to remind people, ACIP does not have a preferential use recommendation for quadrivalent vaccines. In fact, they specifically say that you should not wait to vaccinate in order to procure a different formula of vaccine. Vaccinate with what you have in your office. And that's an ACIP recommendation. This is just information to give you a sense of the diversity of flu vaccines out there. And this is less relevant to all of you because this is adult vaccines, but just to kind of let folks know what's out there. There is a total cell culture vaccine that's out there called FluCellVax from Seqirus. This used to be Novartis, obviously. This is a trivalent vaccine that's approved from adults 18 years of age and older. There is a recombinant DNA influenza vaccine. This vaccine, called FluBlock, is entirely produced by an egg-free process. And ACIP actually preferentially recommends use of this vaccine in those folks with severe egg allergies. Obviously, unfortunately, for the pediatric population, where we obviously think this would have a huge benefit, the vaccine is currently only approved for adults 18 years of age and older. There's a couple of other vaccines. There's a Fluzone intradermal, just to kind of highlight this. This is an ultra-fine needle that's about 90% shorter than the typical needle. It injects the antigen into the intradermal layers, so therefore stimulating dendritic cell engagement. And as a result, it actually has less antigen than the traditional flu vaccine. And a quadrivalent intradermal flu vaccine was recently approved by the FDA. Again, licensed for use in adults 18 to 64 years of age. And then finally, for those over 65 years of age, we do have the Fluzone high dose. This contains 4 times the amount of antigen, 60 micrograms of each of those hemagglutinin antigens. And again, there has been obviously some clinical studies that have been done that shows that this vaccine actually is about 24.2% more effective at preventing primary influenza infection in adults 65 years of age and older than the regular low standard dose Fluzone vaccine. So this vaccine is about 24.2% more effective, and there are 2 studies out there that now confirm this number. So something to keep in mind for those over 65 years of age and older again. Again, a chance to bully pulpit some of this as you get your grandparents and parents coming in with their kids. This is just a chart to kind of show all of you your challenges as you go through flu vaccines. Obviously, there's a huge variety and formulation mix that's out there now for flu vaccines. Of course, I point out obviously your pediatric formulations are also here. If you want to take a look at this, it gives you the vaccine, it gives you the CPT code product, and so on and so forth. This is available on the Immunization Action website, as you can see here at the top of the slide deck. It is a PDF that you can print out and put in your office. This is just to help me kind of remind me, it's my slide prompt to tell everybody that we have over 135 million doses of flu vaccines out there right now. Manufacturers are started shipping as early as July in terms of flu vaccines. And they anticipate bringing about 175 million doses of flu vaccines to the market this year. So there's a huge capacity of flu vaccines, and there is a more than ample supply that's now out there. We do, of course, we are aware, and at the summit phone calls, if any of you have been participating in our summit phone calls, back in September and October, there was discussion, obviously, of the delay in delivery of the LAIV. They started shipping in September, so they were a little bit late. But that now is now back on schedule. They're already on schedule for delivering all their the LAIVs, but it was just into the market a little bit late. And we also discussed the Sanofi Pasteur 6 through 24-month formulation, the 0.25 mil dose formulations. They were also delayed with that as well, which obviously, as we understand, created a problem for a lot of you all as pediatric providers, having to get 2 doses of vaccines into those who are young and need 2 doses, and having these vaccine doses show up a little bit later kind of compress the time frame that you had to give both doses of vaccine. So we appreciate your effort to continue to try to vaccinate these kids with the 2 doses of vaccines, and recognize that the delay did indeed cause you all some challenges. Finally, going to go through some of the ACIP recommendations for flu vaccine. I'm just focusing in now on the general recommendation here that all persons 6 months of age and older should receive influenza vaccine. And this is the ACIP recommendation, and this is that universal recommendation that's been out there for several years now, I believe since 2013. And again, ACIP specifies influenza vaccination should not be delayed to procure a specific vaccine preparation if an appropriate one is already available, just to keep that in mind. ACIP says vaccination should begin as soon as you've got vaccine, and you should continue to vaccinate as long as influenza is circulating in the country. And it says, do not delay to procure a specific vaccine preparation. And here's the link to the actual final recommendations that were published on August 7th. With regards to pediatrics, I just want to point out that if you recall, last year there was that preferential use recommendation that you see here. However, I note ACIP has removed this preferential recommendation for live attenuated influenza vaccine. This happened at the February 2015 meeting. You can see the link here. And so this year there is no preferential recommendation to use LAIV in healthy children 2 to 8 years of age. All right, so again, you can use either IIV or LAIV. There is no preferential recommendation at this point in time. ACIP simplified the algorithm for dosing children aged 6 months through 8 years of age who have to receive 2 doses of flu vaccines. And it's very simple now. No longer do you have to consider the history of the patient with regards to 2009 H1N1. ACIP simply says that if you have a child that has received at least 2 or more doses of trivalent or quadrivalent flu vaccine before July of this year, and you know they've got both doses, all you need is 1 dose this upcoming season. If you don't know that they have 2 doses, or if you know they have not had 2 doses, then they require 2 doses this upcoming season. Simple as that. This is a very easy algorithm. It's much simpler now, and I think hopefully will help our providers out there. What about egg allergies? One of the things to remember is ACIP has now removed egg allergy as a contraindication for flu vaccine. In fact, it's now only a precaution. And that is because a lot of the data that's come out with inactivated influenza vaccine, and which is why IAV is what ACIP recommends for folks with egg allergies, is that there is so little ovalbumin, which is the egg protein that tends to promote the egg allergy, in a lot of these new vaccines that that really it's something that we have to take precautions against, but it's not really a contraindication. And so it's a precaution now for the ACIP. They do say, however, that if you do have somebody that has a severe egg allergy who is of age indication, which means therefore adults, you want to just give RIV, the recombinant influenza vaccine, which is the flu block. But if you don't have that vaccine, they don't say do not administer. They essentially say you should administer IIV, but with a physician with experience in the recognition and management of severe allergic conditions. So just something to keep in mind. Not a contraindication, now a precaution. This is the algorithm that ACIP has put forward, and it's basically to essentially kind of work you through what you want to do with people with egg allergies. And again, even if you've got somebody in this bottom final box with systematic symptoms of allergic reactions to eating egg-containing foods, ACIP does not say do not vaccinate. ACIP essentially now issues this precaution on how you should vaccinate. So something to keep in mind. And finally, I'm going to just wrap up with a quick summary of some of the communication points from CDC for this upcoming flu season. Again, as I mentioned earlier, we seem to be getting some traction with regards to social norming the acceptance of flu vaccination, and that's what CDC is going to continue to build upon to create and sustain these positive social norms that encourage flu vaccine. A couple of objectives. I think these are things that we know we need to kind of focus on. 6 months in age and older should be vaccinated. But again, to kind of foster these favorable beliefs regarding flu vaccine and vaccination recommendations. For example, flu vaccination is the best way to protect yourself and those that you love. Of course, continue to extend confidence in not only just the safety of flu vaccine, but also the fact that there is an effectiveness to the flu vaccine as well, kind of like we talked about earlier. And obviously work on the minorities that we have challenges with, especially in the adult population. And then obviously recognize that your recommendation as a provider is probably the most important thing that gets a patient to accept flu vaccine. This is true both in pediatrics as well as in the adult world. I'm going to skip this slide and just finally talk about two final messaging concepts that we're having to deal with this upcoming season. First, of course, was the fact that we have the drifted strain from last year. So a lot of people are saying, well, why should I get vaccinated if the flu vaccine doesn't even seem to work? So one of the things we want to keep telling people is that we did update the season, this upcoming season's flu vaccines to match what we think will be the most common during the upcoming season. And in fact, the preliminary data would suggest that the vaccine will match this upcoming season. And then also to point out that what happened last season was extremely unusual. So two things happened simultaneously that don't usually happen that way. One strain of flu caused all the cases of flu, or almost all the cases of flu. That was H3N2. And that strain that caused most of these cases drifted to a point of 82% variance from what was in the flu vaccine. Very unusual that all these things happened at the same time. We should probably use this in our messaging to help people understand that this upcoming season is indeed going to be different. And again, based on the information we know now, we believe this upcoming flu seasons will provide good protection against circulating flu viruses. So some resources for you all to go to from the Immunization Action Coalition. I'm not going to spend a lot of time up there. But what I also want to say, and you're going to hear from Shelley right now, but I'm going to also say is that, I always spend a lot of time talking about the data and the numbers and all the surveillance and the coverage. But thanks to Family Fighting Flu for this slide, because I think ultimately I want to bring everybody back and say this is the reason why we immunize against influenza. It's not about the data, it's not about the coverage rates, it's about the people we protect from deaths and complications from influenza. And so thanks again to Family Fighting Flu for this slide and for helping us remember that these are the people we're trying to get to and protect. And you can see there's a huge variation of age range here. We're not just talking about kids, we're not just talking about elderly people. These are folks that span the spectrum of the influenza recommendation. And so based on that, I think I'm going to stop here. I thank all of you for your attention. And Nirja, I think you wanted to take a few questions now and then hand it over to Shelley?
Yes, absolutely. Thank you so much, Dr. Tan. I will now take questions. The panel is on your right side, so please put in your questions, and Dr. Tan will answer them as they come in.
You have a very well-educated audience.
It seems so. Again, we'll keep this open for the next few minutes just to see if there's any questions from anyone.
And folks on the call know that the presentation will be available for later, right?
Yes.
Folks see later, in case they want to put on links and stuff like that. Okay.
The slides as well as a recorded webinar, both will be available after the presentation. Well, you have one comment so far. Great webinar.
Well, I appreciate that. Thank you so much.
Dr. Tan, we do have one question.
Yep.
Any thoughts
Go ahead.
on why the theoretical benefits of the live virus vaccine haven't panned out?
Yeah, I do. I can speculate. And again, this is my personal speculation based on looking at the data. I think if you take a look at some of the early data that showed that the live attenuated vaccine was better at the mismatched strains, a lot of those studies happened early in the time frame of a lot of our pediatric recommendations, so like in the early 2000s. We have a much more highly immunized pediatric population now. I mean, obviously, if you all know, the universal pediatric recommendation started near the end of the 2009, 2010. We started the universal pediatric recommendations, and I think we've got a much more highly immunized population. And then if you think about that, and you think about the fact that a lot of these kids are going to have residual immunity, and you think about the way LAIV exposure happens, which is obviously a live attenuated vaccine that goes into the nose. Mucosal reproduction of that vaccine virus is required in the nasal passages in order for that vaccine to take root. So if you can imagine, if you've already got a highly immunized child, you can imagine how that reproduction may not occur if the child mounts a strong mucosal response against the LAIV. My speculation, right? So therefore, the vaccine actually is hurt by the fact that we've got a nicely immunized population. So that's one speculation, and I think we are beginning to look at this. As I said earlier, we're looking at CDC is looking at the impact of prior immunization on vaccine effectiveness, because you can imagine that some of this may be true also for inactivated influenza vaccine. We haven't seen it yet, but you can imagine some of these hypotheses may be true for that as well. That's one speculation, I think, for why we're seeing this change from data in 2005 versus data in 2015. Hope that answers the question.
All right. You have another question. Do you think that trivalent vaccines will eventually be phased out and replaced with quadrivalent vaccines for all ages?
Yeah, I really do think that's going to happen, and the reason for that is because the demand for quadrivalent is beginning to get stronger and stronger and stronger. And in fact, there is this perception out there, even with providers as well as the public, that the quadrivalent is quote unquote the better vaccine. It really isn't. If there's a match of the B strain, the trivalent is just as good, but there's this perception out there now. So I think market pressure will force all the manufacturers to move to quadrivalent. In fact, as you all know, GSK has already done that, and MedImmune's already done that, and you can see that Sanofi, you can see the writing on the wall, it's already heading that way as well. So I think you're going to see that very soon.
And at what stage of pregnancy is the flu vaccine given, and which vaccine?
So the inactivated flu vaccine is the only vaccine that should be given to pregnant women. Again, because the live vaccine is a live vaccine, as you know, there's a general recommendation not give live vaccines to pregnant women. The pregnancy recommendation is any time during pregnancy. So it's not like Tdap, where you've got obviously that 26 to 36 month frame, but you've got now it's any time, first trimester, second trimester, third trimester. As long as the woman is pregnant during the flu season, they should be vaccinated.
Sounds good. As of right now, we don't have any more questions, but if we have more questions, we will address them after the next presenter.
Oh, thank you so much. I'll stay on the phone.
Absolutely. Thank you. Thank you for your questions. Now I'd like to introduce Shelley Allen from Families Fighting Flu that would like to share the story of her family's experience when her daughter Maddie had the flu. Please join me in welcoming Miss Allen. Shelly, could you add in your PIN for your audio PIN? Otherwise, they'll keep you on mute.
I had to do that too. I think it's hex 63 hex. Is that correct?
There we are. Oh, wait. I think it's depending on the person. There we are.
Okay, can everybody hear me now?
I can, so you should be good to go.
Okay, and how about my slideshow?
Yes, it is up and running.
Oh, perfect. Good afternoon. Thank you for allowing me to speak with you today. Again, my name is Shelly Allen, and I am a member of Family Fighting Flu Organization. I'm also a mother of a 17-year-old daughter who was stricken with a horrible illness at the age of 12 years old. We are fortunate that our Maddie had a better outcome than most children that have had the influenza. It breaks my heart to see so much sadness, but we are determined to tell our Maddie story so that people will learn from us. We truly believe in the cause and want to make a difference. If one person learns from our stories, then we have accomplished something. However, I hope so many more will listen, learn, and vaccinate themselves and their loved ones against the flu. It was February of 2011, and prior to this, Maddie had always been a very healthy, active child. She lived, breathed, and slept sports. If she didn't have a basketball in her hands, then she had a soccer ball at her feet. She loved watching her favorite goalie, Hope Solo, and basketball superstar, Derrick Rose, from the Bulls. Maddie even got the privilege of being the girls' high school manager for basketball. She enjoyed it because she was able to cheer them on, but also she was able to watch and learn. Maddie would try to soak in all the knowledge of the sports she loved to play. Her heart has always been for the game. 7th grade basketball had just finished up, but Maddie was already in gear for indoor soccer and getting ready for her travel soccer in the spring. On February 18th, Maddie went to a friend's birthday party, but a couple hours later, she texted me and said she thought she better come home, that she wasn't feeling very well. It was Friday, and over the weekend, she ran fevers and had a bad cough. Nothing I felt was too over-concerning. We just thought it was the cold or the flu, so I continued to give her over-the-counter medicine to break the fever. On Sunday night, she was very uncomfortable and her back started hurting. So my husband and I decided we would take her to the pediatrician on Monday morning. Throughout the night, she did not sleep well, and we noticed a slight change in her breathing. The next morning, we waited for the doctor's office to open so we could get her in. I suggested that she take a shower because I thought it may help. She asked me to help her because she did not have enough strength to do it herself. I remember closing the curtain to get her a towel, but when I opened the curtain back up, I knew something was seriously wrong. Maddie went from very pale, almost yellowish, and her eyes were dark and sunken in. It was 7:30 a.m. on February 21st, and we immediately rushed her to the hospital. Once there, they placed her on oxygen and did x-rays. They knew she had double pneumonia. My husband and I talked, and we decided she needed to be transferred to a bigger hospital about 30 minutes away. So my husband rode with Maddie in the ambulance. By the time I got to the hospital, Maddie was in respiratory distress, and the doctor needed to intubate her. I went into Maddie's hospital room and explained to her that she had to be put to sleep so the doctors could give her strong medicines to make her better. I didn't know what else to say, but I just knew I needed to be strong for her and not show how scared I was. However, she knew, and I could see it in her eyes. The tears came rolling down my face. Her last words to me were, "Don't cry, Mom. I love you." Those were the last words. I heard from her for the next 5 weeks. Things went fast, and her health declined even faster. Around 8 or 9 p.m. on that same day, the doctor came into the waiting room. By this time, it was filled up with all Maddie's loved ones, her basketball coach and her best friend. And the doctor asked to talk to me and my husband. I knew in my heart it was not the talk I wanted to hear. She told us that there was nothing more that they could do at this hospital, that she has called in St. Louis Children's Hospital. She said Maddie needed to be placed on a special machine that was the nearest hospital that specialized in ECMO, life support. By the time the flight team from St. Louis Hospital got to Maddie's room, she had been placed on the ventilator, and had 14 different IVs. They worked on her for 3 hours to get her transferred to their bed. The trip would take 35 minutes, and they would have to handbag her the whole time. When they got there, Maddie would automatically go into surgery and be placed on ECMO, which does the work for her lungs. I was not able to ride in the helicopter with Maddie, so my sister and my mom drove my husband and me to the hospital. It was the longest ride ever. Every time my husband's phone rang, I just prayed it was not the flight team telling us she did not make it. We finally arrived at the hospital, and I could not walk fast enough to get to the PICU. I just wanted to see my daughter and make sure everything was okay. It was hours later before her doctor came out and talked with us. I knew I needed to see Maddie, so I went and saw her instead of listening to the doctor. I walked into the cold, dim room that they said Maddie was in. I was in complete and utter shock. First, there were so many machines hooked up to her that the only spot I could touch that did not have a tube hooked up to her was her feet. I began to sob uncontrollably because the body that was laying in the bed did not look like my beautiful daughter. They had to put so much fluid on her that it made her face so swollen and all her freckles were gone. She walked into the hospital at 95 pounds, and now I was looking at a 150-pound girl. As I was getting the reality check of what was truly going on, my husband and family were listening to the words of Maddie's doctor saying it was more than likely she would pass and make it throughout the day. It took many cultures, but they were finally able to diagnose her with influenza B and MRSA pneumonia. Maddie had many setbacks, but eventually was able to come off ECMO after being on it for 2 weeks. That was probably the first time I truly took a deep breath. I felt like I was on pins and needles for those 2 weeks, and I couldn't breathe because it may change things. She still had a long way to go, and we were warned that there were still bad days ahead of us. It took another 3 weeks before Maddie was able to be removed off the ventilator and dialysis. Maddie had several obstacles, but with the faith of God, prayers, our wonderful doctors, nurses, and Maddie's incredible determination to the fight, she was able to get better. Maddie had only a 1% chance of survival, but after 93 days in the hospital, Maddie was released and we took her home. We are getting ready to hit the 5-year anniversary of her illness. We are truly blessed and amazed how far she has come. Maddie is in her senior year of high school and just signed with Hannibal LaGrange University to play soccer, a dream of hers that she thought she lost after becoming sick. She continues to play soccer, gets exceptional grades, participates in many volunteer programs, and hangs out with friends and family. Recently, we saw the old Maddie in her first home basketball. She played almost the whole game and scored 18 points, which is huge for Maddie. However, she struggled for 3 days with every part of her body aching. Maddie still struggles with illness. She has a chronic cough that she will probably have the rest of her life, gets tired very quickly, always in pain, and we continue to see doctors often. She's a trooper, though, and when people ask her if it stinks to be sick all the time, she says the outcome could have been a lot worse. She tells them she just takes it one day at a time and makes the best of it. She says, I appreciate life and everything I'm given. I think to myself, what a wise girl. She's so remarkable. I tell people that if her insides looked as good as her outside, she would be in a great place. The year Maddie got sick, we were not able to be vaccinated against the flu. We were both really sick with sinus infections and colds most of the fall and winter. Now we make sure we are the first on the doctor's list to be vaccinated, and we encourage everyone that is around Maddie on a regular basis to be vaccinated too. Before Maddie was sick, we did not take the flu seriously. We thought the flu meant that you were only sick a few days, but then you were better. However, that is not the case. My hope is that people will listen to Maddie's story, learn from it, and educate themselves and others about this very serious yet preventable disease. The best advice I can share with all of you today is to get vaccinated against the flu. This season and every year. It's not 100%, but it's the best chance we've got. I don't want you to have to go through what Maddie experienced. I encourage you to go to familyfightingflu.org to read other stories. Most don't have a good outcome, but these amazing parents tell their stories so others can learn from us. I thank you for allowing me to share a short version of our Maddie story.
Thank you, Ms. Allen. That was a truly heartfelt story.
You're welcome. I apologize about my slideshow. I think it missed a few, so I can definitely give it to you, and if anybody wants to see the pictures of when she was in the hospital, those are on there too. I think that always sort of hits home when you see a child in a bed and hooked up to so many machines.
Absolutely. If there's any comments, questions for Dr. Aljian as well as Ms. Allen, please put them in the question box, and we'll keep this open for the next few minutes. So far, it's thank you for sharing your story.
I will say that just something else is Families Fighting Flu is just a wonderful organization. When I came home, I really didn't have anybody to relate to because a lot of people don't talk about the flu as being a disease. And so Families Fighting Flu, was like a home for me. And actually Madison is one of their spokespersons for the organization. They actually flew us a year and a half ago, 2 years ago, to Atlanta, Georgia, and there's several different PSAs that we did that are on that website, and educational pamphlets and posters. So anybody is welcome to go there and request those, and I believe they are all free of charge.
Ms. Allen, so far the comments have been thank you for sharing your moving story. And another one was, that was an incredible one, but I'm glad she is well and she is a great achiever.
Thank you very much.
Well, thank you everyone for joining today's webinar. We truly appreciate both Dr. LJ Tan and Ms. Shelley Allen for joining on today's webinar to share their stories and the updates on flu. Once again, the webinar is recorded, and I will be sending out an email with the link that has a recorded webinar as well as the PowerPoint slides attached. Thank you everyone for joining today, and I hope you all have a great afternoon.